Welcome to a new session on dermatopathology review of Weedon's textbook. And today we are covering the vasculopathic skin diseases. With these backgrounds of beautiful images of confocal microscope of vascular structure, and I know what you're thinking. What is this diagnosis that's showing these lesions on the upper extremity of this poor kid with these microscopic image? So if you want to know, stick around and we'll learn together today of this interesting topic about vasculopathic skin disease. So when I prepared those talks, I use Weedon as outline for my talk. However, I try to cover the current literature, and also I try to use other sources in order to make sure that those lectures are up to date with the current information. So we so far have covered the major 5 different patterns. We said the spongiotic and psoriasiform are confined to the epidermis, and then we said that lichenoid and vesiculobulous are confined to the dermal epidermal junction. We spoke last week about granulomatous, and today we will cover vasculopathic pattern. So just a few notes about this pattern, because when you read the literature, there is a lot of discussion about classification and definitions. So it is a little bit complicated topic if you want to approach it holistically and try to understand the mechanisms, but also try to understand morphology. So in order for us to understand both, I tried to kind of put everybody's point of view into this kind of simplified version of vasculopathic skin disease. So I try to include all the current understanding that everybody talked about in the literature, and in addition to what Weedon kind of summarized in his book. Another point you have to understand is those lesions are time-dependent morphology. So if you are biopsying the skin lesion in the beginning or middle or close to the chronic phase, you will see different patterns within the same pattern. So sometimes there is an overlap. So you have to kind of take in consideration the time. The best time, they say, is within 24 hours of the lesion it appears on the skin, but this is not very realistic in terms of getting appointment and seeing the physician and then taking the biopsy. And the biopsy has to be deep punch in order to, not as deep as the panniculitis as what we will talk about next week, but it has to be deep enough in order to get all the vessels. And when you are getting punch biopsy and trying to get the vessels, sometimes is not very accurate in order to get the vessel in your biopsy. So some authors suggest to do an incisional biopsy in order to, if you want to have a accurate diagnosis for those lesions. So I like this picture, and I like to use it a lot in my lectures, because this is what actually we try to do when we study those lesions in the books and in the lectures. We try to master specific shapes in order to understand the pattern, but in reality those shapes will have overlap. It will be kind of impossible to discuss those different patterns in one kind of snapshot time point in order to get the full picture. However, I prefer this method when somebody, especially starting new or refreshing on those lesions, to understand this specific shape and master the specific shape. It would be much more stepwise way to master this topic. So I hope like this lecture will give you a very good solid knowledge for these complicated diseases. So the first pattern, so there are 6 patterns for vascular pathology or vasculopathic, and that includes vasculitis. So we're not just talking about vasculitis, but we're talking about what happens inside the vessels of the skin. So the first pattern is when you see extravasated erythrocytes without any effect on the vessels, and you see this pattern as non-inflammatory purpuras, and we'll talk about it a little bit more. But in this lesion or these lesions, you will see only extravasated RBCs. The reason being is those vessels become leaky with age, so it is age-related pattern. The second type is when you see occlusion of the vessels, so we call it vascular occlusive diseases, and you will see necrosis, as we understand from physiology, that when you block the vessel you will see necrosis of the skin, and most commonly you will see like this wedge shape pattern. The third pattern is the vasculitis, which is like what we all know about vasculitis, is inflammation of the vessel wall. You will see here lymphocytes, neutrophils, inflammatory cells basically, and you will see fibrinoid necrosis. Sometimes you don't see fibrinoid necrosis because the lesion either like is early, has not like developed the necrosis, or probably the biopsy has not gotten that vessel that has the fibrinoid necrosis. So you have to depend on your features, other clues to help you make the diagnosis. The fourth pattern is you see edema with eosinophils, and this pattern we call in urticarias. All types of urticarias have these features. You will see edema in the superficial layer or sometimes extend to the deeper layer of the dermis with eosinophils. And the fifth pattern is you see neutrophils. We call it neutrophilic dermatosis, and this is the classic basically LCV in the acute phase, the leukocytoclastic vasculitis. And the sixth pattern is basically combined, where you see like a little bit of the one pattern with a little bit of another pattern. So it's like a waste basket type of a group where you see like a different pattern in one lesion. So, and this is what actually Weedon divided his chapter. So the first one is the non-inflammatory purpuras, then the vascular occlusive disease, then the urticaria, and then you have the vasculitis. And the vasculitis has different flavors, the acute, the chronic, and the granulomatous. And then we have the neutrophilic dermatosis, and finally the miscellaneous, or like the waste basket type of vasculitis. So we start with the normal skin vascular histology, or we talk a little bit about what is how the skin acquires his or their blood supply. So imagine you have two pipes, one in the superficial area and one in the deep area, and this pipe is very important, especially in melanoma, because when melanoma or malignant cells reach this level, this is when you start asking for sentinel lymph node biopsy. So this is very important, the superficial plexus of the skin, and we have the deep plexus of the skin, and we have a pipe that connects all the superficial and the deep, and sometimes you see them wrapping around the hair follicle or the sweat gland, the adnexal structure. So in this unit we have the arterioles, which will give rise to the capillaries and then will draw blood into the venules, and these venules are important because they are the site of the antibodies that will give basically acute vasculitis and urticaria, and will play a role in identifying those antibodies in different diseases. So we'll start with the diagnosis, and as usual we compare the normal skin to the pathology skin, and you can pause the video now and try to identify the pattern, at least like which group is this disease from. So we see here extravasated RBCs in the superficial area of the dermis, and those extravasated RBCs will give rise to the purpura. So anytime you see extravasated erythrocytes in the skin, that will translate clinically as purpura. So in this lesion, the purpura depends, the name depends on the size of the purpura. Sometimes we call it petechiae, sometimes we call it ecchymosis, depends how big is the lesion. So this is senile purpura or age-related purpura, and this we see in the non-inflammatory purpura. So moving on, this is a different pattern now, and you can pause the video and try to identify for yourself the pattern. So what do we see here in the skin? We see in the skin, in the superficial layer, we see the skin necrotic, all these areas of the dark red area. And if you look into this area around the adnexal structure and we try to magnify it, you see the vessel is blocked, and all these small vessels are blocked. So clinically it appears as ulcerated, and especially in the lower extremity, and we see it sometimes as related to the weather. So in cold weather the patient will have those lesions because of the antibody will be activated in cold weather. So if you go on high power, you will identify leukocytoclastic vasculitis with thrombosis, and this is cryoglobulinemia. So in this group of vascular occlusive disease, any lesion that will cause blockage. So if you look here into the different lesions, protein C and protein S deficiencies, so anything will affect the coagulation, prothrombin gene mutations, warfarin necrosis, so and so forth. So any lesion will cause a blockage to the blood supply. It will cause vascular occlusive, DIC, purpura fulminans, thrombotic thrombocytopenic purpura, thrombocythemia, cryoglobulinemia, cholesterol, antiphospholipid syndrome, factor V Leiden mutation, and Sneddon syndrome. So what is Sneddon syndrome? If you see here in this picture, we see this net-like pattern of the leg, and this happens because of vasospasm. We call this livido reticularis because of this net-like pattern of the leg. So this happens when the vessels narrow because of vasospasm, so it appears on the skin as livido reticularis, and this happens because of many reasons. Compare this to the below picture where you see you see a little bit of the large vessels, but you don't see this net-like pattern. So when the patient comes, and we had actually one case last week, we saw this patient, and I haven't seen like enough of these cases, very rare. We call it livido racemosa because you see this like these vessels because they occlude, but not the net-like pattern as you see here. So Sneddon syndrome is you see livido racemosa along with the hypertension and brain vasculitis. So when you see this triad, vaso-occlusion with hypertension and brain vasculitis, we call it Sneddon syndrome. CADASIL stands for cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. So it's very long name, but very important disease you have to remember for your exams because they like to ask what type of mutation. So it's Notch 3 mutation on chromosome 19, CADASIL. So we're moving on to a different pattern now, and you can pause the video and try to identify the lesion. So this is the lesion compared to the normal skin. So what do we see here? We see here around the vessel there is an inflammation. If we go on high power, we see all these vessels are attacked by lymphocytes and neutrophils, and you see all these debris, we call it leukocytoclasis. All these are debris because of the neutrophils. After they are attacked and die, they go into apoptosis. So you see all this debris of the neutrophils because of the vasculitis. So if you look clinically, especially in kids, you will see affecting all these like purpura-like or papules. Sometimes they make ulcer in the lower extremity. And if you do diff, you will see IgA accumulating around the vessels in the superficial layer of the dermis. So this is Henoch-Shonlein Purpura, and sometimes also you will see the kidney with IgA effect. So this is not all the time, but sometimes it affects the kidney. So this is a leukocytoclastic vasculitis, predominant IgA deposit on the skin biopsy. It presents as diffuse abdominal pain with acute arthritis or arthralgia. Sometimes the renal involvement appears as proteinuria and hematuria. So for this category, we will use the a little bit extra source to try to understand this type of vasculitis. We will use the 2012 revised International Chapel Hill Consensus Conference. And here you see that it divides the vessels based on size. So we have large vessels, medium vessels, and small vessels. So in the large vessel category, we see two diseases, Takayasu and giant cell arthritis. So in the medium vessel category, we see Polyarteritis Nodosa, Kawasaki disease. And in the small vessels, we see two categories, the immune complex small vessels and the ANCA-associated small vessels. So in the immune complex small vessels, we see a cryoglobulinic vasculitis. And notice here the cryoglobulinic vasculitis we saw in the occlusive category. So in those type of vasculitis, you will see an overlap with other groups. IgA vasculitis, the one we already talked about, Henoch-Shonlein, hypocomplementemic urticarial vasculitis, anti-C1q vasculitis, and anti-GBM disease. With ANCA-associated small vessel vasculitis, we see the microscopic polyangiitis, granulomatosis with polyangiitis or Wagner, eosinophilic granulomatosis with polyangiitis, Shirk-Strauss syndrome. So another important paper we have to take in consideration, the paper by Andrew Carlson. And here he shows that the biopsy depends on the biopsy. That's what we were talking about. If you do shave biopsy, you will not be able to capture all the types of vasculitis. So notice here, for example, in the HSP, you only see the superficial. So if you have HSP, probably you will get away with the shave biopsy. But sometimes you need incisional biopsy in order to get the large vessels like PAN, GCA, nodular vasculitis. We'll talk more about it in the panniculitis section. But notice here that the different vessel size will affect your ability to diagnose the vasculitis. Another important aspect of Andrew's paper is using kind of mathematical algorithm. He doesn't say that clearly, but I kind of imagine that he uses this kind of mathematical algorithm to come up with the diagnosis. So I came up with this table just like based on his paper. And if you look here, if you take in consideration the vessel size, and then you take the cell type, so we have small vessel with neutrophils, and then you do diff, IgM and IgG, you come up with diagnosis, so LCV, UV, or CLA. Let's take another example. We have small vessel neutrophil and IgA, so we get HSP and or AIHE. So I will not read all this table for you for the interest of time, but I will leave those tables in the description of the video for you to download those tables, and hopefully will help you to identify the diagnosis based on these table, because you can definitely like come up with the diagnosis. They are different, they have different cell type and different vessel size. So in terms of like the acute vasculitis, so we said vasculitis come in three flavors. We have the acute, the chronic, and the granulomatous. So in the acute vasculitis, the mechanism is we have, as we talked about, we have antibody that form immune complexes, which is absent in the microscopic polyangiitis. But for the rest of the acute vasculitis, this is the mechanism. So this antibody could be ANCA and IgA class anti-cardiolipin antibodies. So what happens is those antibodies will activate the complements, and then the complements will attract the neutrophils, and then the neutrophils will attack the vessels in order to cause the acute vasculitis. So that's what you see, or this is the mechanism that causes the acute vasculitis. And we have all these different diseases that we will talk about in the acute vasculitis. So you can pause the video now in order for you to identify diagnosis, and try to look compared to the normal skin. What do you see different? What is the pattern here if you look into this lesion? So in this lesion, we see in the dermal area, so the epidermis appears uninvolved, intact, but the dermis appears very busy with all these blue, kind of like purplish formation. And if you go on high power, you will see that those cells are made of neutrophils, and there are some collagen that they look kind of wispy, or they look kind of congested. So if you look on clinical examination, you will see these lesions. They form kind of annular with a raised border erythematous lesions on the extremities. So they appear as persistent red violaceous and yellowish plaques and papules and nodules, reaction to bacteria and even viral antigens because of various cytokines like IL-8, and there is always IgA, ANCA, but sometimes we have cases like negative for IgA, ANCA. And like we said, it affects the acral area and in symmetric and also on the buttocks. So this lesion is, we call it Erythema elevatum Diutinum. And elevatum means elevated. As we said, we have raised border, and erythema because they are erythematous, and Diutinum is just long standing. Diutinum, the word means long standing. So moving on, this is we are still in the category of the acute vasculitis, and you can pause the video now, try to identify this lesion. So we see here also in the dermal area, we have busy dermis filled with neutrophils or maybe lymphocytes. We don't know. We have like inflammatory cells. If we go on high power, we identify like those collection of inflammatory cells. Most likely they are lymphocytes, and they are forming like a granuloma. They are not granuloma, like similar to the granulomas we discussed in the previous chapter, where we see like lymphocytes, histiocytes, and giant cells. Here, collection of lymphocytes forming kind of like granuloma formation. And those cells, if you go on high power, you also identify eosinophils. So those cells, not just lymphocytes, but also mixed of lymphocytes, plasma cells like these here, collection of plasma cells, and also we have eosinophils. So if you go on the clinical history, this lesion mostly on the face. Sometimes, some cases they reported not on the face, but the majority of those cases will be on the face, and it is single lesion, uh, well demarcated, and looks like a granuloma, and that's why they call it Granuloma Faciale, or if you like the English pronunciation, Granuloma Faciale or G facial. So these are asymptomatic brown, red plaques, nodules, sometimes papules on the face. And in male patients, they are associated with the prostate carcinoma. There is increase in IL-5 of those in the body. And usually they, around the vessel, if you stain for PAS or PASD, usually the eosinophilic fibrinoid material, it will stain by PAS, and we call this toxic hyaline because of this PAS staining around the vessels. IgG and C3 usually granular in the basement membrane and similar to lupus erythematosus. And with EED, the case we discussed earlier is difficult to differentiate. So you have to use the location. This lesion is on the face, EED is on other parts of the body, most commonly extremities and the trunk. And also they say that in Granuloma faciale, usually the eosinophils are higher than EED. So moving on, this is a new lesion, and you can pause the video now and try to identify what is the diagnosis. So in this lesion, we see in the superficial area, we have the superficial dermis appears edematous, a little bit edematous. And then if you look on the superficial dermis also, we have perivascular inflammation. And deep dermis also has perivascular inflammation. So if you look clinically, they affect these lesions affect the toes and the fingers, and most commonly in the cold weather. So this is perniosis or chilblains, and the main features we see is fingers and toes and ears, sometimes the thigh, and subepidermal edema. As we said, there is edema in the subepidermis. Superficial and deep vascular, perivascular inflammation, mostly lymphocytes, and the vessel wall are affected, and usually if you go on high power, you will see edema, vascular changes, and sometimes they are called, especially in the lupus perniosis, you see this vascular change, similar to the lichenoid changes we see in lupus, and affects also the periecrine area. If you look here, for example, around the ecrine area, around the ecrine glands, you will see a periecrine lymphocytic infiltrate. So moving on, this is a new lesion. So if you want, you can pause the video now and try to guess the diagnosis. And what do we see here in this lesion? So if we look on this area, we see basically the dermis looks a little bit paler, or the pink texture looks different than the normal texture that we see in the dermis. The other thing that you notice here also, the blood vessels, they appear dropped, or they appear atrophic. So if you go on high power, you start seeing those areas that they have like kind of sclerosis inside the dermis. So if you look at the clinical pictures, they look like crops of papules, erythematous papules on the trunk, especially on the back. So this is a malignant atrophic papulosis, or Degos. Degos disease, they say, is there are only 50 living people, and there are 200 cases reported in the literature. Usually you see, in addition to the skin diseases, you see GI infarction. appears as crops of papules umbilicated on the trunk. And usually, if you look with the dermoscope, you will see a white porcelain center. And the scar, of course, because of the, so this is at the end, at the beginning of this lesion you will see the vasculitis. If you take biopsy at the end of those lesions, you will see scarring, and usually there is a thrombosis that affects the endovascular area, that and that's the mechanism. They think nobody knows exactly what happens of these patients, but the suggested mechanism is there is an irritation or there is an inflammation into the endothelial layer of the vessels, and that's why you see there is like an irritation, and this will activate the coagulation cascade and will cause thrombosis, and those vessels will start to drop or basically atrophy, and that's what you see here. And at the end of the stage you will see the fibrosis that mainly will affect the superficial dermis, and if the lesion is chronic enough, you will see all the dermis is affected. Another thing you will notice in those lesions, the mucinosis, especially from low power, that could appear on kind of like sign that helps you with the diagnosis, but very rare condition. However, very important to know about those vascular pattern, because very important on the test. So we finished, or we talked about the active or the acute vasculitis, and we moved to the chronic vasculitis. So in chronic vasculitis, we have endothelial swelling, the RBC extravasation, and the nuclear dusting usually is uncommon. In those lesions, we have different lesions. So let's see like what do we need to know about those lesions. So in the inherited lymphocytic vasculitis, it happens because of autosomal dominant that affect the mutation affects the chromosome 6. In toxic erythema, this happens because of drugs or viruses. Collagen vascular disease usually affects various organs, and it causes widespread erythematous lesions. And usually you see lymphocytic vasculitis that usually involves both the superficial and deep plexus. In prurigo or in the pregnancy-related lesion, the PUPPP, this is usually toxic erythema of pregnancy. So in this lesion, you see late onset of prurigo of pregnancy, and usually the diff is negative, versus in pemphigus gestationis, you see the linear C3 and IgG. In prurigo of pregnancy, you see, in addition, like prurigo we see in the outside pregnancy, you will see parakeratosis, but focal area. In addition, the acanthosis, and plus minus excoriation with basically bacteria. Girat and annular erythema, we talked about one of those in the spongiotic lecture, Erythema annulare centrifugum, and you need to know this for the test. Usually they look clinically as cord-like border erythema, and if you don't remember those lesions, go back to my lecture on spongiosis, and I talk more in details about those lesions. Usually there is tight perivascular lymphohistiocytic infiltrate, superficial and deep. So in Pityriasis lichenoides, we see in this pattern vascular interface dermatitis and lichenoid dermatitis, similar to the Pityriasis lichenoides that we see in outside vasculitis. And we have two flavors for Pityriasis lichenoides. The PLEVA is the acute form, and Pityriasis lichenoides chronica, or PLC, is the chronic form. And in these, in PLEVA, we see the lymphocytic wedge shape, but less dense inflammation or less dense lymphocytic infiltrate we see in PLC. And clinically, as we discussed in the other chapter, we see the crops and the scaly red-brown maculopapular. So in PLEVA we see the crops versus in PLC we see more like scaly red maculopapular rash. So in PPD or pigmented purpuric dermatosis, this is the progressive pigmentary dermatosis. So Schomburg disease, very common. We see on the lower extremity where we have like inflammation and then a post-inflammatory pigment alteration that will cause this hyperpigmentation of the skin. Usually we see lymphocytic and macrophages in the upper dermis, and usually heavy band-like inflammation of lymphocytes like the lichenoid type. In lichenoid aureus, we see this type like in a heavy band of lymphocytes. And Carlson, in his paper, groups those lesions as pseudovasculitis. So TRAPS is a specific category we need to know about for the test, tumor necrosis factor receptor associated periodic syndrome. So that's what TRAPS stands for, and those are autosomal dominant periodic fever syndrome. They happen because of the gene mutation that affects the chromosome 12, TNFR SF1A, and because the pathway is activation of the interleukin 1b. So the third flavor of the vasculitis is the vasculitis with granulomatosis. So those are, we talked about in when we discussed the consensus paper, those are granulomatosis with polyangiitis, lymphomatoid granulomatosis, eosinophilic granulomatosis with polyangiitis, lethal midline granuloma, giant cell temporal arteritis, Takayasu arteritis. So in addition to the vasculitis, we see in addition to the features, the fibrinoid necrosis and the lymphocytic infiltrate, we see giant cells. So usually kind of more like a granuloma formation around the inflammation. And as we mentioned, this is from the paper that I showed earlier. So moving on, we talked about different categories, and now we move on to the urticarias. So in urticaria is you see dermal edema, and basically the collagen bundles are separated because of the edema, because of the water. And differential diagnosis, you have to always differentiate this from mucinosis. In mucinosis, you see granular, stingy, basophilic material in the interstitium compared to the edema. And also we see dilated blood vessels and lymphatics. So if you look on high power, you will see endothelium swelling. And the infiltrate will be mild. You will not see a lot of inflammatory cells. Mostly you will see eosinophils and a lot of edema, especially around the vessels. Those are different diseases. Those are physical urticarias because of rubbing or because of like clothing, cholinergic urticaria, angioedema, urticarias caused by histamine releasing agents. So all related to basically allergy, IgE, mediated urticarias, immune complex mediated urticarias, urticarial dermatitis, Snizzler syndrome, autoinflammatory urticarial syndromes, idiopathic urticaria, autoimmune chronic urticaria, and miscellaneous. So all these different examples, but the same morphology. You will see edema, eosinophils, and low cellular component. So you can pause the video now and try to describe or identify what is the diagnosis. So what do we see here? We see in the superficial or subepidermal area, we have kind of edema. We have clearing of cells, no cells, and then we have this huge infiltrate of inflammatory cells. So if we go on high power, this is all neutrophils and neutrophilic debris. All these neutrophils with their apoptotic materials that happen because of the high turnover basically cycle. So if you go on high power, you will see all these rashes, patches, and papules. So this is sweet syndrome, or the other name to it is acute febrile neutrophilic dermatosis, kind of description of the symptoms and also the histology. So in this disease, we see abrupt, tender, painful erythematous plaques and nodules, fever, malaise, neutrophilic leukocytosis, and it associated with leukemia, atypical PG, and infections and drugs. So this is the category that contains all these diseases that has neutrophilic component to them. So we talked about the periodic fever syndrome, and this syndrome has the pyrine gene superfamily. Basically, the patient will have periodic fever in addition to neutrophilic skin inflammation, or is called familial Mediterranean fever. A microbial pustulosis of the folds, as the name implies. We have pustulosis and usually sterile without bacteria. Sweet syndrome we already talked about. Bowel associated dermatosis arthritis syndrome. Rheumatoid neutrophilic dermatosis, acute generalized pustulosis, Behçet disease or Bahjat disease, as the name in basically Arabic, after the scientist who the disease named after. So we see oral ulcers, genital ulcers, and anterior uveitis and ocular lesions. So usually this disease has mucosal ulcer with mixed dermal infiltrate, vascular proliferation, and acanthosis on histology. So I'm done with the chapter, and then we'll discuss some few examples under the microscope. Let's look at different examples from Path Presenter for those different lesions. So here we have a lesion that this is a punch biopsy from acral skin. As you see here, top layer has a compact corneal layer. So this is either the basically the hands or the feet. And then you look at the epidermis look uninvolved, and the subcutis, there may be a little bit of inflammation, but for the most part is uninvolved. So mostly dermal lesion. And in the dermis looks busy, looks almost like infiltrate, but if you go on higher power, we have the collagen areas looks like entrapped, so almost like it looks like dermatofibroma or granulomatous kind of pattern, the same pattern we saw in the palisading pattern. However, we are in the vasculopathic chapter, so definitely this is not granuloma, this is not dermatofibroma, cellular dermatofibroma. So if we go on higher power and try to cruise around, you will see all these very, very beautiful, very abundant neutrophilic infiltrate around the vessels and also around the lesion. Although, like you see all these collagen bundles that almost like it can mistaken by looking from low power, it looks like dermatofibroma because of these entrapped collagen. However, you see all these neutrophilic infiltrate with this fibrosis. Maybe this is at the medium kind of like not chronic yet to become fibrous. So this is Erythema elevatum Diutinum. As we said, because clinically it's long-standing and it has like this kind of elevated erythema borders. So Erythema elevatum Diutinum basically infiltrate with neutrophils around the vessels and with this collagen. If the lesion is chronic, it can become more sclerosis, and you will see like these kind of the collagen pulling away from the lesion, leaving those white spaces. So let's take another example. So we have this punch biopsy, and those lesions are not in order of the chapter we discussed. So we're just like going through random uh, examples. So if you look from low power, let's go to the low power image. The skin and the epidermis appears a little bit maybe acanthotic, but for the most part it looks uninvolved. And then the subcutaneous area, we don't have it here. So probably this is like not very deep punch, maybe like 4 millimeter or so punch biopsy that doesn't have the fat, maybe a little bit of the fat. So if you go on high power, you start seeing that the dermis is basically the action is happening around the vessels and maybe a little bit at the superficial layer of the dermis. So if you go on high power and try to identify those vessels, you will see the vessel wall is involved with neutrophils, and there is like some edema between the collagen layer, and there is fibrinoid necrosis around the vessels. So this is LCV, or leukocytoclastic vasculitis. And if you look on high power, you will see like all these debris, leukocytoclases, they call them. Basically, they are neutrophilic debris, and these are just beautiful examples of LCV. So LCV, the second lesion, all these fibrinoid necrosis, and you see the neutrophils attacking the vessel wall. Very beautiful example of leukocytoclastic vasculitis. Moving on, let's take this lesion. So here we see in this punch biopsy, from this power we have a space, or we have edema in the superficial layer of the dermis, and also we have the dermis is busy with infiltrate. So if we go on high power to see what is in this area, so you see like edema, wide space that between this infiltrate and the epidermis. The epidermis appears uninvolved, but the dermis is busy. So if you go on high power, all these cells are neutrophils. Very beautiful example. So when you see those two, when you see a huge infiltrate of neutrophils with superficial edema, this is characteristic for sweet syndrome. Very beautiful example. Edema and neutrophilic infiltrate. So let's take another case as a punch biopsy. It looks like a little bit deeper than the previous ones. And if you look here, we have some acanthosis and some hyperkeratosis. So it looks like a scaly lesion. So all these lesions that clinically they appear scaly, you will see like all this hyperkeratosis, parakeratosis, some acanthosis, and we have some inflammation around the vessels and around the eccrine glands, even in the deep area. So if we go on high power and try to identify the pattern, we start seeing all these vascular changes in the epidermal dermal junction. So this is basically vascular interface pattern. So this is basically lichenoid lesion. And when we go on high power, we have infiltrate that is lymphocytic infiltrate that affects the basically the superficial mid dermis and also periacrine lesion. So this is PLEVA, pityriasis lichenoides, and if it is the acute phase, we call it PLEVA. If it is the chronic phase, we call it PLC. So in this case, the clues are basically you have a scaly lesion. Like we said, we have a little bit of thickening of the corneal layer. We have a vascular interface, and we have superficial, deep, and periacrine inflammation. Very nice example of PLEVA. Let's take another example. So this is also punch biopsy, and here we have the deep fat. So this is very deep punch biopsy. So whoever took this biopsy, he wanted to get the subcutaneous fat. Is almost like more than 6 millimeter punch biopsy, and as you see in this punch biopsy, the epidermis and the dermis, there is like some inflammation in the dermis, and there is maybe some acanthosis here, but the main pathology we see is the subcutis. So if you go on high power, you will see the medium vessel is involved with inflammation. So this is all inflammatory cells, mostly eosinophils, and we have vasculitis. So this is a nice example of polyarteritis nodosa. So this is one of those lesions we will talk about more also in the panniculitis, where you see the involvement of the deep vessels and also the surrounding fat. Not commonly seen the lobular panniculitis, but in this area we see the vessels, and especially here, if you look here, we see the fibrinoid necrosis, and around the vessel wall also is involved with inflammation. So this is very nice example of polyarteritis nodosa. We are including this here to talk about the vascular pathology, and we will talk about more the panniculitis next week. But very nice example of polyarteritis nodosa. So let's take another example. So this is another punch biopsy and also deep. So whoever took this biopsy also wanted to assess for the fat. So what's going on here? So if you look into this area, the epidermis appears okay until here we start seeing that the epidermis is sloughing. So, and this, if you go on high power, this vessel is clogged, is completely blocked with a coagulation material. So if we go on high power, also there is a coagulation material here. And the specimen in general, the dermis appears pale. And in those cases, so we are, if you look also the superficial area vessels, they appear also clogged. So all these vessels appear that they are clogged with coagulation material. So this is very nice example of Atrophie Blanche. And so this is a coagulation or occlusive vasculopathy that cause the blockage, and then you see this atrophy or this paleness of the skin in this very nice example, Atrophie Blanche. Let's take another example. So this is we discussed earlier, and we said that the epidermis or the skin appears also necrotic and sloughed, and if you go on high power, you will see that the vessels are blocked with this very pinkish material. So this is a Cryoglobulinemia, and this is the mixed type. Another example of the, it's like an overlap between the vascular occlusive group and also the vasculitis group. Let's take another example. So this is a punch biopsy, and if you look into on low power, you will see the epidermis appears okay, except for the superficial layer of the dermis, and some of the deep vessels appears inflamed. So if we go on high power, and if you remember, we discussed this in the spongiotic chapter. So if you go on high power, you start seeing that the epidermis appears spongiotic, and we have some inflammation. So what's going on with this vessel? If you remember, we talked about the coat sleeve pattern. So this is Erythema Annulare Centrifugum. The pattern of the vessels, they appear like a coat sleeve, and the perivascular inflammation type of vasculitis, you see lymphocytic vasculitis with the spongiosis of the epidermis. This is also another overlap case. Very nice example of Erythema annulare centrifugum. So let's take another example here. So we have this sponge biopsy and it looks also deep. And if we assess from this power, the epidermis appears okay and involved. And the subcutis, there is like some congestion, probably some blood, procedural blood. But the main pathology we see here is the dermis. And if we start going on high power, we see important two pathologies. The first one is the superficial layer of the dermis appears spared, and this is what's called the grains layer. And you see like all these inflammatory cells appear like a collection of inflammatory cells like granuloma. So if we go on high power, try to see what is the cell type of these granuloma, mostly are lymphocytes, but we start seeing more eosinophils also, like these cells here. 1, 2, 3, all these 1, 2, 3, 4, all these are eosinophils. So this is Granuloma Faciale, is the kind of the counterpart. See here, more eosinophils. The counterpart of the EED we talked about, and we see here more like eosinophils and granuloma formation. They are not granuloma, but those lesions, they are on the face. So if you get this case, the main things you have to look for is the inflammation, that is a collection of lymphocytes and mainly also like eosinophils, sparing of the superficial layer of the dermis called Gran's zone, and then you have the inflammation. Sometimes if you get this lesion in later stage, you may see also fibrosis. So granuloma faciale. So let's take another example. Here we have the sponge biopsy, and looks like it's from an acral skin because of this thick corneal layer, and then the epidermis, for the most part, could be a little bit acanthotic, but for the most part it looks uninvolved. And the main pathology here we see in the dermis, so in the superficial and deep periadnexal area. So if we go on high power, you start seeing the lymphocytic infiltrate around the vessels and around the adnexal structure. So this is Perniosis. So very classic example and very nice. You see acral skin, lymphocytic perivasculitis, and periadnexal also infiltrate of lymphocytes on an acral skin. Very nice example of Perniosis.